All right, bang. Today is Thursday. It is April 25th. Welcome to the Dog Walk presented by Barstool Sports. Today, Chief and I are joined by Dr. Christopher Salerno. He is a cardiac surgeon from the University of Chicago. Doc, thanks for coming in. I know you got a lot more important things to be doing than talking to us, so appreciate it.
Well, thanks for the opportunity. I'm really excited to be here.
Yeah,
we're thrilled to have you. You're our first cardiac surgeon to sit in that chair. So
first.
Yeah.
And there's been an assortment of people, garbage men, there's been mailmen and stuff. So it's great to have you.
You're moving up.
Yeah, we're moving up a little bit. Yeah. So like what? I guess usually we kind of start with like the daily thing. So today you did perform surgery.
I did.
Well, how many did you do today?
Just one. I was in London yesterday. I got back late last night, so I did one operation and had meetings in the afternoon.
Okay, and how many surgeons are there at the University of Chicago?
We have a 6+, let's put it that way.
Okay.
Cardiac surgeon.
Correct.
Okay.
Mm-hmm. Is that a lot? Is that the right amount, or what's?
It's pretty typical. I mean, we have to cover programs at 3 hospitals, 3.5 probably. We do collectively probably close to 1,100 operations a year, and a lot of that is weekends and nights. So it's not just too much for one person to do, but trying to figure out what people have a life too.
Mm-hmm.
Yeah. How do you manage that? Because I feel like it's such a high stress job. How do you find time to sneak away, do podcasts, or even just like take a vacation day?
Yeah. I think when you go into this cardiac surgery, you don't realize how much you give up. I always tell people, you give up some friends, you give up a lot of hobbies, you might give up your health, but what you get back from your patients is amazing. So you carve it away. I mean, I take probably 6 weeks a year where I'm out of the office, either at meetings or talking or with my family. And we usually don't sleep very much. So you get home at night, you have fun then.
And is it as high stress as like the outside world would think? Like, do you feel that?
Yeah. It varies. Some cases are very routine and you have the music up and you're talking and things are calm. But what makes heart surgery different is every day, if we make a mistake, somebody could be really hurt or die. And so you really have to have the ability, confidence, and an amazing team to make this happen.
What kind of music's on when you're saying the music's up? What's on your playlist? What's your heart surgery playlist?
It varies.
Okay.
Kickstart My Heart. Is that too cliche?
Oh, I like that.
Yeah.
My favorite music is reggae, actually.
Really?
Oh, wow.
Okay.
But not everybody in the operating room appreciates it. So usually it's some alternative.
Okay. How many people are in the operating room with you as you're performing surgery?
It varies a bit from hospital to hospital, but in general, there's an anesthesiologist, a surgeon, an assistant, one nurse at the table, one nurse around the operating room, and then somebody who runs our heart-lung machine.
Okay. And how important is that, making sure you have like a cohesive unit? Like, is it like a starting five in the NBA where you got to know where everyone's going to be? Like your team, it's like, no, I want to, like, that's my anesthesiologist, or is it kind of like a plug and play kind of thing?
You really want a cohesive team. It's not quite like the NBA. Now we're in the playoffs and everybody's cohesive. It's probably more like playing basketball at Kentucky, where every year you have a different five.
Yeah.
Okay.
But everybody knows their role. And even though it's not the same 5 or 6 every day, the pool is not that big. So it's one of 5 anesthesiologists, one of 5 assistants, one of 5 nurses.
Mm-hmm.
Okay. Do you get scared?
Wow. Once.
Once? Just once?
Just once. Where I was doing a case and I had never seen this problem before. And you have to have the humility to stop, ask for help, regroup, and ultimately the patient they find. So we have to be prepared. I mean, almost every night before I do a case, not only do you review the records, but in your mind, you play the operation out. So fear in the operating room is not good for the patient. Preparation combats fear.
What kind of training do you have to do to like keep yourself where that fear never comes in, where you always feel prepared? And what did that look like,
Right.
Post med school and to where you are now?
I took an amazing long path, but 5 years of general surgery training, 3 years of cardiac surgery training, and then every year we're attending conferences, reading journals, reading books, talking to other physicians, probably self-development every month on top of doing this for 25 years is another 10 to 12 hours. I mean, it's really that much continuously.
And how much has cardiac surgery changed from where it was 25 years ago
Totally
to now?
Totally different. I mean, not just are the operations different, but the environment we work in, how ill the patients are, how old the patients are.
Sorry to interrupt. Are you saying are patients more ill now than they were?
Yeah.
Okay.
They're older.
Okay.
There's other options to treat their heart disease short of surgery. So they're older. They want smaller incisions. They want to go back to work faster. They want evidence suggesting what's the best option. So in general, the operations have to be more efficient, and you have to be prepared for a sicker patient.
I don't like hearing that people are sicker now than they were 25 years ago. What do you think it looks like 25 years from now?
I think...
Is it going to be robotics and AI?
Robotic, fewer incisions, catheter base, some things like transplant, you can't do that way, but a lot of things will be without the traditional sternal incision.
Interesting. Is there a type of surgery that you're like, ooh, I get to do this kind of surgery today? Like you get excited professionally?
Every time I do a transplant, it's amazing. It's hard to believe it works.
Yeah.
And it's the gift of the donor, the trust of the family, and a very coordinated team. And it works 95% of the time. It's amazing.
I feel like University of Chicago might even be higher than that 95%.
Yeah, we were probably 96, 98, something like that.
All right. Well, I was reading 100 in the last couple of years.
That's true.
So you can brag about it. Yeah, if you got a 100% success rate, knock on wood. So why is University of Chicago? You guys have the fastest donor times, shortest wait times for donors, and then the highest success rate. So what is your secret at Chicago?
I think it's a comprehensive team approach to transplant. I mean, it's probably the primary focus of our heart surgery efforts. So we've assembled an amazing team of surgeons, anesthesiologists, and cardiologists. We're very aggressive when it comes to organ selection, where the hearts come from, how far we'll go to get them. And then we push it a little bit, but in terms of age and distance. But the patients do well. We also do about 10 to 15 transplants a year of people who refuse to take blood.
So I read about that.
Yeah.
Yeah. And that's usually like a religious...
It is. It's religious Jehovah's Witness group, and it's a lot of places won't do it because if it's not perfect, you not only lose the recipient, but the wonderful gift of the family isn't used. It's really experience. I'm lucky enough to be leading the team now, but Dr. Jeevan Andam was and still is there for over 25 years. And we've recruited the right people.
So going back to the bloodless transfer, because, excuse me, that makes no sense. I like, how do you do a surgery?
Yeah.
What does that even mean, a bloodless heart transplant?
So these are people who refuse is the wrong word, choose not to take blood from another person.
Mm-hmm.
They will take an organ. So we have to optimize them before surgery to make sure they have enough of their own blood. Then in the operating room, it's not just not wasting blood. It's doing everything possible to recover all the blood. It has tremendous benefit for other patients too.
But and what does that look like on the operating room? Because if you're, when you see it on TV, right? And you just see like the bags of blood, put it on. So like, are you recycling it? Like
some of it, yes.
Okay.
Every drop of shed blood in the field, we can recollect.
Okay.
And we actually take some of their blood at the beginning, save it, and give it back to them at the end.
Okay. That just like the description of it, where it's like, it's a bloodless heart transplant. I remember reading about it and being like, that doesn't make any sense. How can that possibly be?
We have the biggest program for this in the country, and people come from not only the U.S. but the world for this.
And do you think University of Chicago is recognized as that?
Yeah.
Yeah.
It's a smaller niche, but people know, and that's why they come.
And were you recruited to come into University of Chicago? Like,
Yeah.
What's your path, your background? I know.
Wow. I was practicing in Indiana. I ran a very big, successful heart transplant program there, but it wasn't number one. It was University of Chicago, and institutionally, there's no way we could have done it. So, it took them 3 years to convince me to move back to Chicago, but best move I ever made.
Yeah. And how long have you been at University of Chicago now?
It'll be 3 years in September.
Okay. So kind of new.
Yeah.
Yeah. New to the hospital at least.
Yeah.
So before we were talking about, your organ placement and the different, and you guys kind of press it a little bit. How do you match a patient to a donor? What's that process like?
Well, the first thing is blood type. That's the first one. If they're the right blood type, then it's size, gender, and then performance of the heart. So we're given a lot of information about donors. And then based upon the unique situation of the recipient, we find the right match. The last step is to make sure that the recipient will not reject the heart. So it's immune testing. If all that works, it's a go.
And is there ever any, like, you get in there and, like, there's a surprise?
Oh, yeah. You mean for the donor?
For either one.
Yeah.
On either side of it.
If our team is at the hospital getting the heart, if there's a surprise, we can stop.
Okay.
We can intervene. Repair it. Minor repair. For the recipient, no. Once we made that decision, it's go time.
Okay. So then nothing. We'll fix what we have to fix, but we're going in.
Moving forward.
Okay.
What would be a surprise that would be kind of scary?
I did a transplant about 2 weeks ago, where the donor, without us knowing it, had an abnormal heart valve. The recipient was very sick, so I elected to take that heart, replace the heart valve, and then transplant the heart, and the recipient did fine.
How long for a transplant? What's the normal time for the total operation?
Yeah. It's a really tough question to answer, but if it's an uncomplicated first-time operation and the donor's nearby, it can be as short as 4 to 6 hours. When it's somebody who's had multiple previous surgeries or needs a lot of work, 12 hours.
So are you slamming coffees? Are you nicotine? What are we doing to keep your mind sharp during? That's a long time to have hyper focus.
It's interesting. I think it's our zone. it's rare that the surgeon leaves. We just are trained to be there. Other team members may come and go, but we're there.
You're there the whole time.
Yeah.
Hey, let's pause for a second here because we want to talk to you guys about ChevyDriveChicago.com. Summer road trip season is coming up quick, and now is the perfect time to get a new Chevy. The SUV lineup and the new Silverado truck have all the space you need to comfortably get to where you're going. ChevyDriveChicago.com has the latest offers on all vehicles and can help you find your local Chevy dealer. Every Chevy is a number one pick. ChevyDriveChicago.com is the official truck partner of the Chicago Bears.
Great. Yeah. Drive up to Wisconsin. It's almost that time for Chicago summer in Wisconsin.
Oh, yeah. We'll be taking your Blazer out there.
Blazer there. I think we're going to do a weekend in Kentucky.
Yeah.
So
we're going to get good use out of the summer road trip season.
Big time.
Chief's new Chevy Blazer that he
the
bought.
more the merrier. We're going to have George in there, though.
Yeah, it's fine.
That? Yeah.
It's fine. Yeah, good dog car. Yeah, I agree. How was it? Are you still enjoying it and everything?
Oh, I love it.
Good.
It's like one of those things where I don't enjoy paying for anything. Every time I pay the monthly for that for the Blazer, I feel great about it. I feel great about it.
Good purchase.
Yep.
Good purchase. So yeah, one more time, go to ChevyDriveChicago.com to learn more today and get yourself a Chevy. All right, let's get back into it.
And no, like if you've never, I'm sure you get calls in the middle of the night, right?
Yeah.
Where it's like I'm only on 2 hours of sleep or less.
Got it.
So
you go.
And you just grab a cup of coffee and go in.
Coffee, eat something. We will leave the operating room, go to the bathroom, get water, but we're there.
Wow.
And are you at the stage of your career like where you're mostly doing transplants?
No.
Or like okay.
No. It's probably 25% of what I do.
Okay. And like I keep equating things to sports terms. Sorry,
Right.
that's just kind of what we do. But is it kind of like double bypasses, like single A, triple, open heart, and then a transplant? Like is the majors like is that an equivalent or is that?
I would say yes.
Okay.
But transplant, a routine heart transplant is probably AAA. What we do is the majors or the all-stars.
Okay. So and that's like the bloodless transplant.
Bloodless,
Yeah.
multiple re-ops, older recipients.
So are the other ones like double bypass and the other, are they kind of just routine now because
A little bit, but there's still a big operation, and people's lives are at risk. Routines are not the right word, but they require less thought probably.
Okay. And is there something that has happened that has been like a huge breakthrough for these?
For transplant?
Yeah.
Lots of things. I mean, when transplant first started, the first 10 or so recipients died within 6 months. Now we have a better understanding of immunology, why somebody can accept or reject the heart. A lot got into how to choose the heart, how to preserve it, and then how to prevent rejection afterwards. So the operation itself, not that different.
Do you ever, when you're done with one of these very complicated 12-hour operations, do you just like pack up and go home? Like it's like, hey, like I'm done here. Hey, we did a few podcasts today. I just go home and it's like no big deal. Or how do you like decompress and what does the rest of your day look like?
I usually linger a bit.
Okay.
Go home, eat a big meal, watch ESPN.
Okay.
Go to bed.
So the sports analogies are hitting home now. Okay. All right. Good. Yeah. Well, when he came back with like, it's more like Kentucky, I was like, all right, we could talk to this guy.
I could work these in.
Yeah.
Is there anything to kind of speak in the future? Is there anything we're on the cusp of that you think could be a game changer?
Yeah. Xenotransplant is coming using animal organs for people. It's been done 2 times at University of Maryland. Getting closer. Lots of options out there for new artificial hearts. Completely implantable, non-transplant. In the last 4 years, the donor pool has expanded based upon taking organs from people who have treatable viruses and using hearts from people whose hearts stopped altogether. Usually, we take a heart from a brain dead person.
Mm-hmm.
So, brain doesn't work. They're declared dead, and we take their heart. Now, if somebody's heart stops for just a short time, you can take the heart, evaluate it, and then transplant.
And so does it just come in a cooler, this
Yeah.
donor? Yeah, literally?
Not always, but most often.
Typically, like a cooler on ice. It's just an organ on ice.
Hopefully, not directly on the ice.
Right, sure.
There's a bunch of new technology to keep it about 5 degrees Celsius.
And how long could it last from?
Historically 4 hours. Wow. New technology, 6, 8, maybe longer.
Wow. 4 hours.
Yeah.
So is like, this just popped in my head.
Go for it.
Tell me if it's stupid or anything. So is this, because what is it, Oregon?
Yeah.
That is doing this thing where you could give up your rights, like if you have like a terminal illness and you want to pull the plug on yourself.
Assisted suicide you're talking about?
Yeah, is that gonna kind of be like a game changer for?
Potentially. So, if somebody wants to withdraw support, and we know their organs are otherwise fine, there may be a pathway to donation. Now, most of those organs come from people with severe brain injury who either they've told people or their family knows they don't want to live like that.
Mm-hmm. So it's a little different, obviously.
Yeah.
If people are sick, or these people are probably
older.
I have a morbid question as well.
All right.
We've obviously seen like a spike in opioid.
Oh, yeah. It's a boom for transplant.
All right, that was going to be my question.
It's a boom.
Yeah.
It's a boom. And those are actually very good organs. They tend to be young, with normal heart function.
Interesting.
Yeah.
Okay. So that they don't get disqualified.
No.
No.
We used to have to, and we talk about it with recipients.
Mm-hmm.
We used to say no, but the outcomes are the same or better.
Or better because they're younger.
Because they're young.
So what would be a big disqualification, like something like cancer, obviously, or
Cancer, HIV, heart disease.
Mm-hmm.
Have there been any? Have you seen it? Because you always hear with like all the COVID that people with COVID had heart issues.
Yeah.
Have you seen any of that?
Yeah, late.
Yeah.
Wait, and you don't know for sure it's from COVID,
Mm-hmm.
but the time makes sense.
Yeah. What does a heart like that look like? That has this
virus.
Yeah.
Usually, they'll be enlarged.
Okay.
They will contract very poorly, and they may be what we call hyperemic, kind of red-looking and fragile. But it would be rare to transplant somebody during that initial phase.
Okay.
Usually they get through it, and then months to years later,
Okay.
transplant.
I asked you this earlier, but you say you take some time off. Do you ever feel like this pull? Like if you're off, do you ever like, maybe do you have like a guilt about like I could be there saving somebody?
We're never really off.
Yeah. Okay. You don't go to like Cabo or anything like that?
I do.
Okay.
But we have email,
Okay.
phones. You're still tethered. You're still
Okay.
making decisions. You still call back. You still
Okay.
checking up.
So you can have your daiquiris and then call in to.
But I'm not operating.
You're right.
Yeah.
Right. Yeah. Of course.
Right.
I would hope when you're not operating. Yeah.
I've been in Hawaii, answered phone calls. I've been in Europe and answered phone calls.
Mm-hmm.
I've only had to fly back a couple times. When my son graduated college, I had just done a very complex transplant. Patient did fine, but I was worried. And it probably was not the best for my son because I was supposed to be there for him.
Mm-hmm.
And I could not completely separate myself.
Mentally or
Mentally.
Yeah.
And I'm not so sure he knew. If he listens to this, he'll know. And I feel really bad about it. But my family understands. I was lucky enough to have been given the opportunity to do this. I love it. I would never have any success without them, and I think they appreciate that.
Did you always know that this was the type of surgery you wanted to do, or did you know from it was medicine, and then did you always know it was going to be cardiac?
Transplant first. My mom had a kidney transplant when I was a kid.
Okay.
So I had that perspective. My undergraduate degree was in engineering. All heart is a pump with valves. It was a normal fit.
Yeah.
I was working as an engineer. Went back to med school to be a heart surgeon.
How long were you an engineer?
About 2.5 years.
Okay.
Yeah.
Okay. So it wasn't like you were like, it's been 10 years.
No.
Okay. Okay.
Wow.
Yeah.
Is out of the six of you,
Right.
are you guys more like, is it more older guys or is a lot of younger blood coming in, or
It's about a half and half.
half and half?
We need to hire some young blood if you know anybody.
I know a urologist. I don't know if he can help you.
No.
Yeah.
It's good to have a mix. I mean, my ideas are different than the young guys. Dr. Jim Am's ideas are different than mine. We need that, we need a team which is heterogeneous. I want what I call T-shaped people, meaning they have one area of depth of knowledge, but enough breadth to be a team player.
Mm-hmm.
And we really need that blend. And we need diversity too. We need not just old, young, but male, female, brown, black, white, everybody. We live in this society which is heterogeneous, and our patients don't all look like me, so I need to have a diverse team.
Mm-hmm. Do you find that we're, the America is in good hands with like the up and coming surgeons and whatnot?
Yeah, although it's different. I think when I finished my training, I felt very prepared to do whatever was thrown at me. Now it's a bit different. I mean, people in training have work hour restrictions. There's a different appreciation for work-life balance. And I think that we're in great hands, but the way we deliver care will look different.
And you say you have this mix of old and young.
Yeah.
Now, you said you were recruited, but being the top program, I feel like you have to be very selective.
Yeah.
What is that process like? Hey, we need a new team member. Where do you even begin to find someone? And how do you know they're good without seeing them operate?
Well, we do. The first thing is we don't hire people without going to watch them operate.
Okay.
There's not that many heart surgeons in America. So, there's Kevin Bacon, 7 degrees of freedom from everybody. So if I want to hire somebody who was trained at Duke, I would call my friends at Duke and say, what do you think? It's probably similar to sports, right? You don't draft somebody without doing your homework.
Yeah. Pre-scout, yeah.
So that's one. And then do their skills match with what we need? Do they have the right personality? Are they a team player? And then the last thing is, can we provide the environment that they want to make them successful? And that's often the hardest part.
How many would you estimate that we have? How many heart surgeons are in America? You said there's
10,000 or so.
10,000.
Okay.
Okay.
And is that the smallest specialty?
Probably.
Yeah.
I mean, this week I'm going to Toronto for a international meeting, and I will, not personally, but by name or face, know pretty much everybody there.
Oh, wow.
Are you, and Dr. Jeevan for that matter, are you guys kind of celebrities when you walk into the, there goes the Chicago guys?
Sometimes.
Sometimes?
I mean,
okay.
It's like everything else. There's a different celebrity this week than last week.
Mm-hmm.
I guess we need a bigger social media presence.
Well, here you go. Glad you came in.
Go.
Yeah. Saw you guys on the dog walk.
That's right. Well, I mean, our contributions are recognized. I mean, let's put it that way. I mean, it's sometimes awkward for me. I think I mentioned I was in Prague about a month ago for a transplant meeting, and people come up to me and call me doctor rather than Chris, and they ask me questions or ask me. One guy asked me to sign a paper I wrote, and it's very bizarre. And my wife was with me, and she's like, "What is wrong with these people?" I sometimes forget that. You know, I mean, I want to consider myself that typical guy that when I was in med school, I walked to Glasscott's and, you know, had a beer and I was like everybody else. That's who I am.
Yeah.
I'm just lucky enough to do something that not everybody else gets to do.
And you feel lucky to do it?
I do.
Yeah.
I do.
You get great satisfaction out of it?
I do. I mean, it's demanding. There's times where you need a break, but I feel very lucky.
Have you had surgeons on your team before that they get to, I'm making up numbers, well, they get to 45 years old and they're like, burnt out.
And then they'll do something else.
Yeah.
You can reinvent yourself.
Yeah.
After surgery.
Hey, let's pause one more time because Chief, please tell us about this new Top Spin 2K game.
It's awesome. We have the big 2K studio upstairs at the Barstool HQ. The Top Spin game is absolutely incredible. It's got the authenticity of the pros from Serena to Federer to Alcaraz, Osaka. They have all 4 Grand Slams. So if you want to be down in Australia, you want to win Wimbledon, what's the other ones? U.S. Open, French Open, Roland Garros, it's all great. So you can do a deep My Career and My Player experience and the top brands in tennis apparel and equipment. It is like the real experience. Head, Nike, New Balance, Wilson, Adidas, whatever, Lacoste, all those like the brands that you associate with tennis, they're all in the game. Even John McEnroe's in the game. So if you need a little Top Spin Academy, John McEnroe does all the voiceovers for that, so that's going to be a great experience. It's a truly social sports experience, so you can do it locally or online in multiple player offerings, including the World Tour and 2K Tour with ranked and unranked matchmaking, leaderboards, and daily, weekly, and monthly challenges.
Nice.
Yeah,
See where you stack up.
Exactly. You always want to be pushing yourself, competing. It makes everything a little bit better. So pick up Deluxe and Grand Slam Edition today. So go out and do that. It's topspin2k.com if you need more information on where to find it.
Awesome. Let's get back into the show. I talked to someone kind of in the surgery realm, and they asked someone for advice on a certain surgeon. They're like, hey, what do you think about this guy? And they're like, well, I trust him to do something minimal, but I wouldn't trust him to do like a big thing. What are like the big intricacies that you see in a surgeon where you're like, he doesn't do this well or he does that well? Like
when you're doing your scouting.
Scouting.
Yeah.
The first thing is, as before about to get afraid. Do they have composure in the operating room? It's really important. 2 is, can they direct the team? You know, when I'm with a coach, we're like the quarterback. You know, you have to call the audible and direct people and make decisions constantly. If something goes bad, how do they react? And then, do they have the skills to do this? So, most people can learn how to operate in terms of sewing and tying, but to make it like easy, effortless, fluid, that's a gift. That's not as easily learned.
Yeah, so people could throw a spiral, but they can't do a hot route, call a check down, everything. That makes a lot of sense. But in my head, I was like, wait, what happened? Is his incisions like just a little sloppy or something? Yeah.
They play more. It's sloppy. It's the people in the room are not following them.
Yeah.
Or
there's like a leadership component. Yeah.
Yeah.
That's interesting too.
This is also interesting.
Yeah.
I mean, this kind of everything. Because even like you said, so you think we're like what? Because we use like pig stents, right? Is that a thing for like valves
right?
and whatnot?
Yeah, well, Big valves, yes.
Yeah.
Okay.
So like, what is the pig the animal we're that close to using a heart for?
Probably because pigs can be yes, short answers. Yes, I mentioned xenotransplant. The pig is the best model for that, but if you transplant a whole heart, it'll keep growing. So you have to modify it not to grow, but their heart valves are very similar to ours.
And what's the youngest you've ever done?
1 year old.
A 1-year-old?
Yeah, I wasn't transplant, but when I first worked in Seattle, I operated on a 1-year-old. But in training, I'd operate on, not as a primary surgeon, but as a trainee neonates, hours to days old. I have a partner, Dr. Vercella. He runs our pediatric program over at Advocate Children's. He operates on newborns all the time.
And does that feel different?
Yeah, I mean, I think not only do the tissues feel different, I mean, the way the skin, the bones, all that feels different. The expectations are different. The margin for error is different. But for kids, you have to plan for a reoperation. In the adult world, we hope it's one operation.
Yeah. So reoperation for, what would it be for?
Growth.
Okay.
Changes.
Okay. So just things that are like they're going to happen. You
right,
want them to happen almost.
Correct.
Yeah. Okay. Okay. And then when you, back to like the donors, if you open up that cooler and you'd be like, ooh, that's a good heart.
Yeah.
You can tell right away just by looking at it, or?
Usually.
Yeah.
Young, not a lot of fat.
Okay.
Pink.
Okay.
Yeah.
Can you clean up the fat? Is that something you can do or no?
It'll damage the heart.
Damn. Okay.
Yeah.
Okay. Okay. And then, what about like other? I'm trying to think. As a cardiac surgeon, do you look at people, like, oh, that drive-through line at McDonald's, like that's.
Oh my God, that's one of my vices.
Okay, one of your personal vices.
Yeah.
Okay.
Yeah.
What's your order?
It depends. If I get done late at night, and I'll sometimes just get the extra large Diet Coke and a large fries and eat on the way home.
Okay.
I'm all about keeping the car clean, so you can't eat a Big Mac while you're driving.
That is a fact.
I do. I think life is about moderation, though, right? So you shouldn't eat McDonald's every day, but a burger every once in a while is probably okay.
Gonna be okay.
Yeah.
And then how much like academic work do you do now? Are
Yeah.
you still publishing, and is that something you enjoy too, or is that like a box to check?
No. I think physicians in both academic medical centers like University of Chicago and Northwestern and in private practice are all very interested in innovation, development, new ideas. At University of Chicago, that's our foundation. We want to be innovative on the forefront. So there is rarely a day that goes by that I'm not involved in development and research of something. I may only publish 10 to 12 papers a year.
That feels like a lot.
But as a department, we're publishing hundreds.
And then and is that for like what is the purpose, I guess, of publishing that many times a year?
The first thing is altruistically, it's because you want to make medicine better and you want to help more patients. Obviously, there's probably some personal gain from it too, but that's short-lived. And the best medical research is a clinician sees a problem and says, let's fix it. So think about the first heart transplant. Dr. Shumway, who I was lucky enough to spend quite a bit of time with, realized there was a clinical need to give people new hearts. And from that, he figured it out, and after doing lots of research it was finally done. And that work started in the 60s. And now, 60 years later, we have a durable fix. And it's a gold standard for heart failure. But it's not just heart surgery. It's most of the biggest breakthroughs in medicine are because people identify a specific clinical need.
You said how lucky you feel with helping people out. I would imagine, given that you have notoriety doing this, that one of the harder parts is when people find out who you are and they reach out to you like, hey, someone in my family needs a heart. And is there a sense of, I don't know if guilt is the word or something like, how much does it bug you that you can't obviously help everyone?
Well, we try. Let's start with that. We try.
Mm-hmm.
Some people, they're not candidates, but the biggest limitation now is donors. Still, I think I probably reflect more on success than failure, although maybe learn more from failure. But when a patient dies waiting for a transplant, or in a rare occasion afterwards, it's not just them. We know their family, their story. It's hard. And I think every surgeon has a little cemetery in their brain, and they remember every failure.
You think every surgeon has that, or you think that's
the best?
Yeah.
Wow.
So I don't know how you carry that.
Yeah.
That's a tremendous, like you said, you feel lucky. That's also sounds like a tremendous burden to carry with you all the time too.
I think maybe it's when you get the hug from a grateful family member, maybe you feel a bit better.
Mm-hmm. Yeah, it's got to be hard because I imagine you just saying that probably had some things floating in your head. It's like,
think about it all the time.
Yeah. Wow. Is there another obviously cardiac surgery is very major.
Yeah.
But when it comes to brain or anything else.
I think neurosurgeons have as tough a job, if not a harder job in some ways. And I think some of the abdominal transplant surgeons actually take care of some maybe even sicker patients, liver transplant team or some of those folks. But what makes the heart unique is, for many of us, we see it as the center of our being.
Mm-hmm.
It has different symbolism. So it's a bit more personal. I mean, you asked me before about do I feel lucky.
Mm-hmm.
So earlier today, I operated on somebody. I held their heart in my hands. We fixed their heart. And I go back to my life. But, I mean, that's an unbelievable amount of trust and privilege. And, I mean, I constantly ask myself, am I earning that trust that this person is giving me? And if the answer is no, then I know it's time to do something else.
Mm-hmm.
How much time do you think you have left? Like you've been doing it for 25 years.
Yeah.
Do you have like an end date for yourself in this field?
I know. I mean, I'm 58 now. I figure I'll operate probably another 10 years and stay involved in the field after that.
Mm-hmm.
I think I've come to realize that even when your days in the operating room are over, you could still contribute. And I think that I'll never not be a heart surgeon.
Yeah, I mean, I wasn't sure if there's like a process, like a pilot, where there's like a hard retirement date or anything. But
not for us. There are. I know people operating into the mid-70s.
Really? Okay.
Yeah.
I don't think I'll do that.
Yeah.
Not for you.
Yeah.
Yeah. Because I
turn the phone off when you go to Hawaii when you're done. Yeah.
Yeah. Exactly. You could watch sports and.
Yeah.
I mean, it's. I can imagine a time when I may do something else.
Mm-hmm.
I mentioned I was an engineer. I might go back to product development. I might trying to improve my golf game, I might.
We can walk you down in the simulator when when we're done here.
Yeah. A lot of options.
Yeah.
Maybe someday I'll be a grandparent.
Yeah.
Who knows?
Yeah, that'd be cool.
Yeah.
All right then, Chief. Anything else?
I think I'm all set. Yeah.
Good. Doc, thanks for coming in.
Yeah, thank you so much.
Yeah.
It's great having you.
Appreciate it.
Yeah, learned a lot.
It was fun.
Yeah.
For real. So, all right. Is there any, like you said, you got to pump up the social media or something? Do you have something that people could find or anything like that?
I don't actually.
Okay.
We have a website.
Okay.
That's about it. I need Twitter.
I don't know if you do. It's an interesting place, but
we'll just get a little like a GoPro on your head next time you're doing a surgery.
Yeah.
Walk us through it, put it on TikTok.
Can I say go Cubs?
Of course. Yeah, this is a Cubs room. Yeah.
Let's go.
Yeah.
Let's go. All right then, Doc. Thanks a lot. We appreciate it.
Take care, guys.
Awesome.
Thank you.
That's it, everybody. Thank you for listening. Thanks for watching. We'll see you guys on Monday.